Dr. Chris Booth as our speaker for this month's HSPRI rounds. I think a few around the virtual room probably know Chris, but for those who don't, he's a professor in departments of oncology and medicine at Queen's, the director of Division of Cancer Care and Epidemiology at the Cancer Research Institute, and a Canada Research Chair in Population Cancer Care. I've named that, right? Have I, Chris?
Yeah.
Yeah. So wonderful, and importantly for this connection, a member of HSPRI, a longstanding member of the Health Services and Policy Research Institute, and I suspect many on the call have seen a lot of news from a trial that Chris and team have run recently around exercise for as part of cancer care, and we're excited to hear a little bit more about that study today and potential health services and policy implications of that. So I'll welcome Chris. Thank you so much for joining and speaking with us today, and I'll pass it over to you.
Great. Thanks, Jordan. Thanks for the invitation, and nice to see many familiar faces and friends from HSPRI here today. Just a sec. No, it's not. All right, there we go. Jordan, can you see those? I think so,
Sure
yeah.
can.
Perfect. Thanks. Great. Okay, I changed the title to make it a little bit more exciting. Sweat Science, Spandex, and Cancer, the story of the challenge trial. But don't worry, I left my spandex bodysuit at home. So this story actually goes back 20 years, but ultimately it led to a presentation in Chicago in early June at our big cancer meeting and a simultaneous publication in the New England Journal of Medicine. But the backstory is quite interesting, and so I'm going to tell a little bit about the story of the trial, the methods and results of the study. But then the last part, I think, will be probably, I'd be very grateful for kind of comments and insights from this group, given their expertise and interests about how do we actually operationalize this and move this into policy and practice. As Jordan said, this really exploded. So my life is starting to get back to normal now, but for a little while it was pretty abnormal. I mean, I went from BBC to New York Times. It was, and I think it just speaks to kind of the fact that a concept like this captures the imagination of people worldwide and kind of generate a lot of interest. And so we're hoping to capitalize on that interest and translate this into policy and practice in the very near future. But it's been covered by people who are much better speakers than I am. So Dr. G, who does some very amusing medical spoofs, I'm not sure how many of you have seen his spoofs, did a cover of our study, a summary of it for the New England Journal of Medicine. It was very well done. So you can see him there, very short of breath and sweaty as he ran up the stairs to get his exercise steps in to prevent his colon cancer. And then I'd never heard of this guy, Hank Green, but the teenagers, my teenagers, they weren't that impressed with the New York Times or the New England Journal of Medicine. But when Hank Green did a 30-minute episode about the challenge trial, they thought that was pretty cool. So this is a guy in the States. He's like a YouTube guy that is extremely gifted at teaching science. I'd never heard of him before. But the kids, apparently, this is like half of what they do in Ontario high school now in science is they watch this guy. So this guy's like teaching our kind of, next generation. He's very good. So you probably should have invited him instead of me. But he also kind of did a very amusing and well done summary of the trial. So why did we do this? About 20 years ago, observational data sets emerged suggesting a strong association between exercise and cancer survival. But as we all know, because these were observational data sets, they're confounded by the fact that patients who exercise regularly are different in many ways from people who do not. And so I remember the observational studies came out in JAMA and JCO, and I think it was JAMA had an editorial saying this is intriguing, but someone needs to do a randomized trial. And I was young and naive enough to think that, okay, well, maybe we should be the people to do it. At the same time, there was laboratory data supporting a number of anti-cancer mechanisms of action of exercise. And so in 2007, we started writing this protocol, and it was the first randomized trial in the world specifically asking the question whether exercise can improve cancer survival. And the first patient was randomized in 2009. Um, so the backstory, though, is I think kind of interesting. So again, it's a convergence of science and serendipity and maybe a bit of spandex. But I was a young oncologist. I had just finished my training in Toronto, Princess Margaret Hospital. I'd moved here to Queens to be a research fellow at the Canadian Cancer Trials Group, which I'm sure many of you know is a jewel in the Canadian research ecosystem. And I was also a former varsity distance runner. So I had an interest in cancer and clinical trials, and I was a long time interest in athletics. Um, and I went to a fall meeting. I think it was in a dark hotel room near the Montreal airport. And there was a conversation about running a smaller randomized trial to see if physical activity could improve chemotherapy-related fatigue. And there's a lot of interest in doing that. And I thought it was a good idea. And again, I have to, maybe give credit to my younger and more naive self because I guess I had the courage to raise my hand and say something to the extent of, this is a good idea. It's probably going to work. Exercise is going to make people feel better and their chemotherapy-related fatigue will be improved. But this isn't going to really change anything. People are not going to change policy and practice, I don't think, for a fatigue endpoint, even though maybe we think they should. I said, what we should really do is aim much higher. Have you guys seen these data that were published last month by Jeff Meyerhart and Michelle Holmes? And I said, I think we should be aiming to try to improve survival. And so I'm sure everyone was rolling their eyes saying, who is this young whippersnipper? Like, this is 20 years ago, right? This stuff was way out in left field. But there was enough senior and thoughtful people in the room, and I'll always be very grateful for mentors and leaders at the trials group who were willing to, indulge this young oncologist. And we started developing the concept. And at that time, I was introduced to my now longtime friend, partner in crime, and collaborator, Professor Kerry Cournier. Kerry is a professor of kinesiology at the University of Alberta. He was the study co-chair with me of the challenge trial. And he is a behavior scientist who has spent decades working with people who have cancer using randomized designs to see how to deliver lifestyle and behavior change interventions to get them to improve their exercise. So Carrie and I started working together from day one. And so it was, a world authority professor with a young, naive oncologist, and there was a little bit of magic in the air. And so the first draft of the protocol is here on the screen. So I was taking a graduate course in epidemiology here at Queens. It was called Principles of Randomized Trials, taught by the legendary Joe Pater. And there was no exam. There was just one class assignment. You had to write a phase 3 protocol. And so this was my course assignment, was the first draft of the challenge trial. And of course, me and Joe never thought this would really go anywhere, but Carrie and I started pitching this to the trials group. And I think we pitched it 2 or 3 times over the period of about a year before finally they said, okay, yes, we're going to do it. And the Canadian Cancer Society was the funding agency. Very early on, we realized, I should mention that what happened then was the sample size for the fatigue trial went from 200 up to 1,000 patients to try to improve survival. So as soon as they approved it, we had a bit of a celebration and then a panic and realized, okay, we can't do this alone in Canada. We need partners. And one of my colleagues, a fellow from Princess Margaret Hospital, Dr. Jeanette Vardy, she had just returned from Toronto to her native Sydney, Australia, and was junior faculty. And I remember I phoned Jeanette using a real telephone because that's how we communicated. This was so long ago. And I said, Jeanette, we've got this crazy idea. We want to study exercise and can improve cancer survival, but we need a partner. Are you interested? She said, Chris, we're in. And, it sounded easy, but she was junior faculty. She had to get her own funding. So she wrote a major operating grant and got several $1 million in funding from their version of CIHR. And the Australians joined us from day one. So, yeah, as I tell the trainees, kind of listen to your younger self and be open to kind of wild and crazy ideas because sometimes they actually go somewhere. So the study design, it was quite a pragmatic design. So just taking a step back for people who are not familiar with cancer. Colon cancer is one of the most common cancers. The standard treatment for people who have localized disease is they have surgery and then they get between 3 and 6 months of chemotherapy afterwards to reduce the risk of the cancer coming back. We know that there's a need for improvements in delivery of care for these patients because about 30 or 40% of them, despite getting surgery and chemotherapy, will relapse and typically die from their disease. It's often incurable when it recurs. So these were patients who had all finished surgery and chemotherapy. They were randomized to the control group, which was given an information booklet of health education materials promoting healthy diet, exercise, healthy living, or the experimental arm. And the patients got the same booklet plus a funded, essentially personal trainer life coach for 3 years. And the goal of this physical activity consultant, and depending on the center, it could have been a physiotherapist, a kinesiologist, an exercise physiologist. There was a number of different phenotypes. The goal of this physical activity consultant was to work with the patient over 3 years to ramp up their exercise and sustain it over those 3 years. So the ramp up period was the first 6 months. And the target exercise levels was to increase exercise by something called 10 MET hours per week. And so I didn't know what a MET was until I fell into this space. So a MET is a unit of energy. One MET is the unit of energy we'll all expend sitting here quietly for an hour, even if I put you to sleep. But if we went outside on University Avenue after this and went for a brisk walk for 1 hour, brisk enough we're huffing and puffing, or as my colleague Carrie says, Chris, you have to be walking fast enough that if someone saw you, they thought you had robbed a bank. So it's a real walk. If you walk for an hour, that's 4 METs. And so to hit this 10 MET target, the exercise prescription could include any form of aerobic exercise. And essentially, they would review what does the patient like to do, what's feasible in their lifestyle, what kind of exercise have they done in the past, and came up with a plan. And this could be anything from swimming to biking to kayaking to cross-country skiing or running. We saw it all. But what most people did was a walking program, and they could hit their targets by going for a walk between 45 and 60 minutes at a time, 3 to 4 times per week. So certainly a commitment, but we're not talking about training for a marathon or a triathlon here, but definitely a commitment. The program was really rooted in theories of behavior change. This is a behavior change intervention delivered over 3 years. Each session involved coaching sessions and supervised exercise. For the first year, they met every 2 weeks, and then it was monthly in year 2 and year 3. The next couple of slides have been borrowed from one of my colleagues, Dr. Arthuso, who's a postdoctoral fellow in the exercise oncology lab of Kerry at University of Alberta. And so these behavioral support sessions, the first half would be reviewing things like goal setting, motivation, time management, self-monitoring, setting targets for the next few weeks. And then there would be a supervised session of exercise on a training bike or a treadmill. And it was all rooted in, what Carey had been working on for 20 or 30 years, these theory of planned behavior change, which was anchored, and this is his expertise, not mine, but anchored in the concepts of how we can work with behavioral beliefs, normative beliefs, and control beliefs to move from beliefs to intention to behavior. And so there's a 55-page manual that people followed in each of these sessions over the 3 years that directed this behavior change intervention. The primary study endpoint was disease-free survival, which is really a composite of death and also recurrent cancer. And it was defined as recurrent colon cancer, new colon cancer, another primary or death. Lots of secondary endpoints, of course, including overall survival, quality of life, and measures of physical fitness. And we banked blood at multiple time points on all 1,000 patients. So there's a lot of correlative work that will happen in the next few years. The power calculation was aiming to detect an improvement in disease-free survival that we know had changed practice when a new drug came out several years earlier. So we were pragmatic. We targeted an effect size that we thought was reasonable based on the observational data, and one that we knew that would change practice with clinicians. Accrual was slower than expected. A few reasons for that. Firstly, these major international trials, this one really never got US buy-in. They supported the idea, but they just never participated, and we never got broad support from European centers. So essentially, this was run through Canada and Australia, which has the population of California and Texas. So, big international trials running in California and Texas. The accrual, therefore, was slower. We also learned that although patients love the idea of this, by the time they finished chemotherapy, they'd been in the health system for about a year. And the idea of more paperwork, surveys, scans, and blood tests, plus an exercise program, was daunting for patients who wanted to return to work and to normal life. So that's something we can talk about because it does have some, generalizability and policy implications. And then COVID came. So the event rate took us much longer. We thought this would be like a 10-year project, not a 20-year project. And so eventually we approached the Data Safety Monitoring Committee with a blinded request to target an event rate, and we closed enrollment in early 2024. And so we had to compromise, so we lost some power for the effect size that we were aiming for. So the behavior change intervention, again, was these behavior support sessions with supervised physical activity. The first 6 months was about ramping up. The second 6 months was about refining, figuring out what works, what doesn't work, and perhaps even aiming higher. And year 2 and year 3 was monthly touch points that could be virtual, really to sustain and support the person's physical activity lifestyle change. So we enrolled almost 900 patients across 6 countries, 55 hospitals, but the vast majority came from Canada and Australia. The study population was a pretty typical colon cancer trial population. They got the usual chemotherapy drugs, and as expected, based on the natural power of randomization, there was no meaningful difference between arms in other baseline characteristics. Adherence with the mandatory sessions was quite good. It was 83% in the first 6 months, 68% in the second 6 months. And in year 2 and year 3, 2/3 of patients attended all of their mandatory sessions. Like any drug trial, we had to monitor for safety and toxicity. And the only safety signal that emerged was not unexpected, was a slight increase in the risk of musculoskeletal adverse events, again, suggesting an on-target effect of the intervention. The structured exercise program led to a clear improvement in self-reported physical activity, as you can see in the panel on the top left. Both groups increased their exercise. The control group, I mean, they were motivated, they went on the study, they got the booklet, there was nothing preventing them from exercise, so they bumped their exercise. But there was an even greater bump in the exercise of the intervention group. This was corroborated by increased and sustained improvements in their VO2 max and their 6-minute walk test results. And the primary measure of quality of life, the patient-reported outcome of physical function, showed improved and sustained changes over the duration of the intervention. But the highlight and the reason that I didn't sleep for 3 days when we got these results was the primary endpoint was met. So there was a clinically meaningful and statistically significant improvement in disease-free survival with a 28% reduction in the risk of recurrent or new cancer. This translates to an absolute difference at 5 years of 80% in the exercise arm compared to 74% in the control arm. And so putting this into a number needed to treat, for every 16 people who went on the exercise program, exercise prevented one person from developing recurrent or new cancer. And the overall survival results were also astounding, with a 37% reduction in the risk of death. We had very long mature follow-up on these patients, so the median follow-up was 8 years, and at 8 years, 90% of patients in the exercise program were alive compared to 83% in the control group. Again, with a number needed to treat, for every 14 people who went on the exercise program, exercise prevented one person from dying. Notably, we were really interested about what was driving the event. So you can see a clear reduction in recurrent liver metastases, as well as new primary cancers. And intriguingly, a hint that exercise might have effect in other cancers. So you can see quite a striking reduction in the risk of new breast cancers in the women who were on this trial and followed for a long time, as well as new prostate cancers. And this is consistent with the observational data in those diseases as well, which also suggests an anti-cancer effect of exercise. And going back to the survival results, I should also mention that we were curious when we first saw these curves after we kind of caught our breath, was whether this was being driven by a difference in cardiovascular deaths or diabetic deaths. But in fact, it was a clear reduction in deaths from colon cancer that was driving this observed difference in survival. This is a bunch of kind of other drugs that we use in the adjuvant setting to put this absolute effect size in context. So with a 7% improvement in overall survival at 8 years, you can see when we look at some of our other very good drugs in colon cancer, lung cancer, and breast cancer, the magnitude of benefit of this exercise intervention is comparable and in some cases exceeds the benefit of some of these very good and very expensive drugs. And so I'm not showing this to suggest that exercise replaces cancer medicines, but I actually show this mostly to hold my own field accountable to the fact that this is actually a really meaningful advance for patients, and we need to take this seriously and implement this. So conclusions from the trial: the structured exercise program after chemotherapy improves fitness, patient-reported outcomes, and survival. These results demonstrated a novel first-in-class anti-cancer effect. The magnitude of survival benefit is comparable to many of our standard and good medical therapies. The breast cancer data are intriguing and consistent with prior observational data, and there's some questions to be had about generalizability, and lots of ongoing work with biomarkers, health economics, and predictors of adherence. So I think after June, the challenge trial sets a new standard of care. Exercise is not just about improving fitness and quality of life. It can be conceptualized as a form of cancer treatment. The important thing here, and this is the knowledge translation piece, is that knowing these results and knowing the power of exercise in itself will not be sufficient to change patient behavior or to realize these outcomes. In fact, I've heard a few, supportive oncologists say, "Oh, this is amazing. We get this for free. We just need to tell patients to exercise." But I have to remind them that, in fact, that's what the control group was. And so the benefit, the survival benefit, was because of the behavior change intervention. And so we need health systems to invest in these supports. This intervention is empowering and achievable for patients. The back of the envelope, we're doing a formal cost effectiveness analysis, but the back of the envelope cost for the number of hours of a personal trainer kind of phenotype is in the range of $3,000 to $4,000 over 3 years. And so in my anti-cancer drugs cost $100,000 or $200,000. So as one of my colleagues said, the cost of exercisumab is a rounding error in the monthly budget of our chemotherapy. So this is sustainable for health systems. And again, I think the challenge trial serves as an example of the questions that academic cooperative trials groups can answer that are important to patients, but that no one else will be willing to undertake. So what now? How can health systems implement exercisumab for colon cancer? And this is where I think the hard work, it's already started, but is ongoing. So we need a policy case with costing and implementation plan. We've started working on that. There's a formal cost-effective analysis underway. We've done some modeling, assuming that all patients participate and attend these sessions in Ontario. Again, I think we'd be lucky if 50 or 75% of patients choose to accept this offered treatment. But the cost is in the range of $3 to $6 million per year, depending on the delivery mode, and assuming all patients participate, it would be substantially discounted for those, obviously, the proportion that don't. And this is a lot of money, but just to remind our listeners here that Ontario spends $2 billion per year on cancer drugs. And without spilling the beans on the cost effectiveness analysis, I can tell you that this is going to be extremely favorable. And you can imagine, just by reducing the use of palliative chemotherapy and reducing the number of new cases of breast cancer, this has very favorable implications overall for the health system. So we started to kick around different delivery models, and there's many here. And in fact, what's interesting is, in some ways, there's an implementation paradox here, because if this was a drug, it would already be funded and approved, because there's budgets for that, there's a pathway for that, and it would already have gone through the committees and be available in cancer centers everywhere. So there's a paradox, because we've got a treatment that's just as effective, doesn't make people sick, and costs like a 20th of the price, but it's actually much harder to implement. So the delivery models we've thought about, there's a decentralized model where the funding follows the patient. You can imagine a patient is given a list of potential providers in their community. The patient goes to see that physiotherapist, trainer, kinesiologist, and either the provider is reimbursed or the patient gets reimbursed for that, like a health spending account that many insurance plans have. I think there's a lot of advantages to this, but I can imagine this is going to blow the mind of the Ministry of Health when it comes to kind of implementing it. So the other model is, the cancer center, a direct delivery model. We get funding to have social workers and dietitians. Maybe there can be funding for an exercise consultant to be embedded in the cancer center. There's some challenges with that. Patients would have to travel back to the cancer center. Not everyone wants to come back in the cancer center. We don't necessarily have the space, the expertise, or like the physical kind of training facilities for this. Another model is to piggyback onto the very widely distributed cardiac rehab program. So this is already up and running. So can we use that infrastructure with increased resources to move forward there? And there's a number of community-based delivery models. So partnering with family health teams, partnering with home care, partnering with local gyms or YMCAs. And so I think that there's a lot of interest in exploring this. And the reality is that it's probably going to be a different model depending on the jurisdiction and the context for different patients in different centers. So lots of outstanding questions. How many patients will accept this treatment? Are services going to be restricted only to colon cancer? Where's the best place for delivery? How is this going to vary by center and geography? How many sessions should be in person versus virtual? Who's going to fund it? And again, just the implementation paradox. If this was a drug, it would already be available. But I think this is an opportunity, and I think health systems, particularly, I think we're well positioned in Canada to have a chance to be the world leader to implement adjuvant exercise. And this is clearly patient-centered, empowering, effective, sustainable, and achievable. And so that's the end of the formal remarks. But thanks for the chance to be here, Jordan and colleagues. And I look forward to any questions, comments, and advice from the experts here about how we can move this forward through policy and implementation.
Wonderful, Chris. So much in there to unpack, and what an incredible body of work that you've shared, but also get our head spinning, I think, in terms of what those next steps could be as as health service and policy researchers. I'm sure our heads are all spinning around those next steps that you outlined and all of the things yet to unpack around how that can be done. I'd love to open it up to anybody who has any questions or ideas for Chris. Marianne.
Yeah, hi, Chris. Is there a champion in the ministry? I mean, is there someone whose ear you have and who's speaking on your behalf?
Yeah, I mean, it's a pretty this story kind of sells itself. So I mean, we've gone as high, Chris Simpson, John Irish, like the very senior people in Ontario Health and Cancer Care Ontario are very supportive of this. They believe in it. They like the fact that this is kind of Canadian grown. And so they've opened doors, and I've had invitations to speak and present these data at very senior tables. The question is, where's the funding going to come from? And who's going to take ownership for this? The oncologists love this idea, but they'll get uncomfortable. This isn't really their space, right? They're going to want to know where to refer these patients. And so I know that there's already, in fact, we were managed, one of my colleagues, Dr. Yuchen Lee, a kind of junior faculty oncologist here in Kingston, managed to get some foundation support. So we've actually been able to launch a program here in Kingston. To my knowledge, it's the first formal program in the world to implement the challenge trial, where for the next few years, we can refer our patients to colleagues from the Faculty of Kinesiology at the Revved Up program here at Queen's to get really involved in doing this, which is really exciting. And so this is starting to happen. I've got dozens of emails from patients around the world who have financial means to go just hire their own trainer, and they're downloading the protocol from the New England Journal of Medicine. And they're doing this. But I am a little bit worried and want to hold the oncology community and the Ministry of Health accountable to the fact that this should be publicly funded. I think that I would like to see a model where someone gets diagnosed with colon cancer, the system provides the surgeon who operates, the system provides the oncologist and pays for my drugs. I would then like to be able to refer the patient to a funded exercise specialist to deliver this intervention. So I think it's going to take some time for that model to roll out.
I'm delighted to hear about the relationship with Revved Up. That was exactly where my head went. And the other one that I think of as a sort of a model from the disability world is self-funded attendant care, direct funded attendant care, which has been successful in Ontario, and I think it's still active.
Okay.
But I mean, it came with all the usual concerns that, well, what if the person just takes the money and goes out and buys himself a new car? But those were the hurdles that were overcome by that.
So Marianne, what's the name of that program?
Direct funded attendant care.
Attendant care, direct funded
attendant care. Yeah.
So that allows people to hire their own attendant and get funded for it.
Hire, train, and supervise, and fire if necessary.
Who's eligible for that? Like what patient or cohort?
People with severe disabilities. It's mostly quadriplegics and that sort of cohort.
Amazing.
And they get an annual allotment and self-manage.
That's very helpful. I wasn't aware of that, Marianne. Thank you, because we've been looking for a model where this kind of funding could follow the patient. Okay, great. I'll circle back to you about that after the lectures.
Yeah.
Thanks.
Go to Catherine, and then Mir's question online. I'll read in a second.
Yeah, Chris, I remember when Alison Aiken was part of this at the very first conversations, and Patty O'Brien is the study coordinator. It's just like so exciting to see this come to a wonderful end, and just it's all the things I think in the rehab world that we see all the time, but there's rarely this type of level of trial that it explores this. So I just have a few comments and then I'll end with a question. So I just put in the chat, it's called Family Managed Home Care. And so this is available to everybody, actually. Not just, there was a special managed care for people with high needs disability, but it's also available through home care. And I've put the link. I've known people who've used it. It's very complex. You need lawyers. You actually get money from the government to hire accountants and lawyers to get the legal contract, but there is structures in place to show how people can be given money. The other is I want to highlight to you is the autism strategy. So they completely revamped care for individuals with autism, and now families are actually given money, and it for good and bad, I will say, it disrupted services for families with autism, because what happens is, and this is the unintended consequences, people who are highly skilled and can coordinate themselves have access, and the people who don't, who need it the most, can't really do this on their own. So, but I think again, the autism strategy would be the other piece. I used to also, when I worked at the Queen's Family Health Team, the YMCA gave out free passes, and I really like the idea that you also said this is not about just letting people know here exercise, it's about supported exercise, and I think that is also crucial. So my question after all those like talking comments are, is there any plans, and I probably know the answer to this, to do this with other cancers?
Yeah, great question. Thank you, Catherine. I've been taking notes. Those are all excellent suggestions. And this is why, Jordan, thanks for inviting me here, because you guys know about this space more than I do. So that's been very helpful. So there's an ongoing trial in ovarian cancer the Australians have been doing, and they will report in the next month or two. There's a very large study of breast cancer in the US led by Jennifer Ligobel in Boston, and they will report in the next couple of years. But some of the most interesting and gratifying kind of Zoom meetings and phone calls I've had over the last couple of months have been with the next generation kind of oncology scientists and trialists, thinking about how they could take this, modify it, and launch it. So in the US, there's major movement to launch a similar trial in kidney cancer, and I think there's discussions about doing this in other cancers as well. It does get to, I could make arguments on both sides. Like, we should generate evidence so we can implement policy and practice. But the reality is this intervention in the cancer space is unlike anything else we do in oncology: surgery, radiation, drug therapy. The risk benefit ratio is just so different, right? So, the number needed to treat of 14. So if this was a drug therapy, it means we essentially harm 13 people and save one life. Here, one life is saved, but the other 13 people probably feel better and are having the benefits of exercise that we all know and appreciate. So on the one hand, do we need to be that prescriptive when it comes to implementing this? But I think the reason we did this, because that's the other comment I got when I was a young whippersnapper, and I tell friends at dinner parties about this, they say, like, Chris, like, why are you going to spend 10 years of your life and millions of dollars running a trial of exercise? We know it's a good idea. Just tell people to do it. First of all, 10 years was ambitious. It was 20 years, but the point we made was, everyone knows it's a good idea to exercise, but for most people, it's very difficult to develop a sustained change in their lifestyle and to do that. And so we wanted to show that with this behavior change program, if it was positive, then you could make the argument to policymakers to fund it. And I think that this is an important, I think arguably we should probably be investing in these kinds of interventions across the entire health system, right? As my wife, who's not in medicine or healthcare, often reminds me, Chris, you don't work in a health system, you work in a disease system. And so if we want to work in a health system, we need to actually be serious about investing in this type of work, which is actually highly cost effective.
I've always thought to myself, everyone should be given, as a taxpayer, anyone living in a city should be given a pass to the funded municipal gyms and a bus pass as well, because
Yeah.
the people that I worked with in the community couldn't get to the Y. So it was one thing to give them the Y, but it was
Yeah.
another thing to get there. So again, I always think of the people who can't access this, because well-to-do people often have personal trainers.
Yeah.
So
Yeah.
anyway, thanks for this work. It's just so exciting to see this out there. And I feel like it's the wedge maybe that could get broadly thinking about wellness interventions going.
Great. Thanks, Catherine.
Yeah, I'll go to Mir's question that he typed into the chat. He had a question about which covariates were controlled for and whether any correlation was found.
Yeah, great question. So, I mean, there's a forest plot in the New England paper. The effect seems to be, fairly uniform across every subgroup that we looked at. So certainly all of the hazard ratios they were on the correct side of 1, and almost all of them were kind of below 0.8. So there was nothing that jumped out that suggested a differential effect of the intervention on survival. Some of the data I'm going to present in Europe in a few weeks is looking at, well, what predicts adherence and kind of what predicts people hitting their exercise targets. And what's quite clear, and we're just kind of writing this up now, is that it's the first 6 months that are crucial. And you can predict what someone's doing at year 1, year 2, and year 3 based on what happens in those first 6 months. So this is where I think we really need to ensure that we invest. And, there's already discussions about, well, how many sessions do you really need? But I think without a doubt, the first 6 months are crucial.
Thanks for that. Pat, I saw your hand go up briefly, but then some notes into the chat. Did you have a question, or did you just add them to the chat there?
No, I wanted to express the thought that Providence Care was involved in a lot of the ideas that you're talking about, Chris, but it wasn't necessarily from a cancer perspective. I mean, they're involved in rehab after you have a total knee replacement. I've had 2 of them. I'm thinking about probably going to need a hip replacement after what I play too much hockey. But I guess the idea is that we have some of these things in place that we could probably use to promote this further. And your ideas are sane and sound and well, way better than the chemotherapy drugs that we currently use. And I just wanted to make sure that if there's anything that I can do to be a part of this, to be a proponent for it or to suggest that to our friends at Providence Care, that's probably a good way to go.
Great. Thanks, Pat. Appreciate your comments. And yes, I've already started discussions with colleagues at Providence to learn from them about the cardiac rehab model and how we can piggyback on that.
I might jump in now since I don't see any more hands up, if I may, which because I love how the framing of the discussion has immediately gone to, like, how do we piggyback on existing structures in a way that might make implementation, scale, and spread feasible. And one of the things that comes to mind is just the attention to team-based primary care at the moment and the expansion of primary care teams, and what does that mean for the comprehensiveness of services that are available, and the potential for an equitable solution that's a little bit more closer to home than than a hospital-based program, for example, and whether there might be opportunities to think about implementation through primary care, which I know is one of the bullets of things that you mentioned there. And the other thing that comes to mind that's quite related, and then would love to pause for your reflections rather than posing a question, is really prevalent conditions that would benefit from really similar interventions as a way to support scale and spread. So I'm the recent article, I think last year in the Lancet, called the Walk Back trial, showing that a behavior change intervention for back pain is effective. You don't need a whole bunch of specialized exercises necessarily to improve back pain, that a walking program is actually quite effective for back pain. And so the idea that scale and spread might be more feasible if aligned with conditions that are over 2% of visits in primary care, for example, or things like that. So anyway, just two other ideas with the same philosophy of, like, where can we piggyback on existing system structures to think about how to get these behavior change interventions to people that could benefit from them.
Yeah, thanks, Jordan. I think this is hopefully can be used as a model for testing similar interventions in other spaces. To my knowledge, this is the first clinical trial of exercise that's actually shown a survival benefit period in any context, because I think there's barriers to running these trials. At least in cancer, most lifestyle trials have failed, and they failed largely because patients didn't change X or Y because they weren't supported in such a way to do that. So I think, and this was really the genius of my co-chair, Carrie Cournier, is the integrity and the intensity of this behavior support was really remarkable, I think, in affecting change. And, Carrie had been working on this for 20 years before we launched the study.
Yeah, I agree. There's so many exercise trials that don't have the attention given to behavior change that leads to, potentially failed trials, which is a big challenge. Marianne.
Yeah, thank you. the other thing, obviously, that has to be said when we're talking about research and policy is that, you know, evidence is a necessary but not sufficient condition for policy change. And sadly, it only goes so far. I mean, it's a reason for policymakers to say no to you if you haven't got enough evidence, but it's not a reason for them to say yes. And the reason to say yes, of course, is a political imperative. So it sends you down the track of starting to think about what creates that political imperative. Well, the main thing is pressure from various sectors. And so, well, you probably have a few other things to do, Chris, and you don't want to start a lobbying campaign. It is important for the government to start getting the message that people not only want this, people demand this. And all these other sort of parallel programs that we've been talking about are a great source of lobbying pressure, you know, to say, well, look, you're doing it for these people, you're doing it for those people, you know, have you got something against these people? Yeah, I mean, that's the big challenge, and the challenge that we're not particularly either cut out for or prepared for is getting the attention of government beyond providing the evidence.
Yeah, you're right, man. And I'm learning a lot just in the last, few months with this. We were lucky that the media was all over, so that helped open doors for discussions. But I feel a sense of time urgency to capitalize on that while it's still fresh in their mind to really push hard. So we're going to continue to push. But we've started to engage with the patient advocacy and support groups around the country too, to make them aware of this. But we're also going to engage them in helping us with a loud voice.
Excellent question and response there. Centeyu's question online. I noticed that adherence levels appeared to drop in phases 2 and 3 of the intervention. Did you explore factors, or is there plans to explore factors that might have influenced adherence and the impact on outcomes?
Yeah, that's just the analysis we're just completing now. And the biggest predictor of how you do in the current block is what you did in the previous block. So the drop off later on, we haven't looked at the extent to which that's correlated with survival. But when you look at all lifestyle intervention trials, this adherence was actually pretty good. It's pretty high.
Yeah.
And the fact that 2/3 of patients, attended all their appointments in year 2 and year 3 was decent. And then, you wonder about the other third, and probably it's a mix of people who just bailed and didn't do it, or the people who are already like now training for half marathons and just didn't need to bother going anymore. So, but it's a good point, and stay tuned. We'll have some more news, I think, that in the coming months.
Thanks for that, Catherine. Oh, you're muted, Catherine.
I'm just going to build on Marianne's comments again about the policy change because, Chris, there's like such a policy. I'm not going to say there's a policy window per se. There's like a swell of interest. And I think to pick up Marianne's point, I wonder what that policy window where governments would actually be then willing to, they're listening because it's in the news, but are they actually open to make changes? I'm going to use the example like older adults and long-term care. I mean, nobody wants long-term care, but the government is like wedded to this belief that we need institutional care. And so, I mean, because of the strong lobbyists, and I'm just going to circle back, how do you get around the lobbyists, obviously, of like the drug companies? Like, how do you have a compelling counter argue? Not that this data doesn't, but like for actual policy change.
I think it's going to be the patient narratives. I think you're right. I think, I feel this sense of urgency since the media reports were so powerful, but once we have the health economic analysis too, it's going to be very, very hard to ignore because the punchline is that this is an intervention that saves lives and actually will save the health system money. And we're going to keep pushing that narrative. It would be kind of insane to ignore it. And I think, when we talk to people, they genuinely love this idea and they want to do it. It's just kind of this awkward space about it's a hot potato. Like, well, who's going to be responsible for it? Who owns this? Where are we going to find the couple $1 million, which is like basically nothing in the context of a health system. But yeah, I'm pretty determined. So we're going to keep pushing.
That's awesome.
There's been great suggestions today for me to get some ideas about these alternative models. So thank you all for that.
Are there other examples that anyone here on the call knows where everyone talks about we're going to reroute money, savings into something else, but I've actually never seen that happen. Everyone talks about like the big picture and reroute. Has anyone seen that where they actually demonstrated something A was effective and then they took dollars B and put it in. I've actually never seen an example of that.
I haven't either, but even, in this economic analysis, even when you account for the $4,000 it's going to cost for the intervention, it's a net savings. It's still the economic impact is such that our drugs are so expensive. You just need to prevent a few people from getting them or a few recurrences. So it's, we're hoping that'll capture their attention.
Yeah, if I can just add another, that the other thing that I think is really compelling about the case that you're making, Chris, and I think will be compelling for government, is you're doing all the thinking for them. And I don't mean that they're not capable of thinking. Of course they are, but they're thinking about different things than we are. And so I think you have to make it really easy for them and just say, this is the best way to do this. There's evidence that this delivery method works from your attendant care outreach program or from your, whatever program that you already funded. And I just think you have to make it so easy for them that, and not sort of go to them and say, you need to spend this money and you need to do more, but just to say, we want this program, we want it delivered in this way, we want it in these 10 communities, we've already got buy-in from those communities, blah, blah, blah.
Yeah, I agree. One of the things I've been speaking to kind of, potential donors and foundations that are interested in this, and I've just been making the case like we need some modest funding now, like for the next 6 months, to hire someone to really build that policy implementation case, which is not going to take years. We can do it in months. And I think you're right. Make it so that this could be modified into kind of a memorandum for a cabinet or a ministry decision.
What comes to mind with a potential challenge upcoming to those conversations is how the language in the Canada Health Act. So when we think about, for example, the provision of care from rehab providers that might be good at supporting this, or kinesiologists, or that kind of thing, is the idea of getting that paid for and whose responsibility to pay for it is the challenge of how the Canada Health Act refers to medically necessary hospital, physician, and certain surgical services, basically, as defined as what the health transfer is dependent on. And so the idea, not that you want to make this a bigger challenge, is but redefining what medically necessary care means to include things beyond physician and hospital-based care, which is an argument that is key to the cancer discussion here, but also to so many other, effective interventions that are hard to mobilize because it's easy to I guess defer the responsibility for payment for those because it's not, specifically explained in the Canada Health Act.
Yeah, no, you're right. That's one of the really big picture issues. No, that's great. Jordan, I need to run. I'm sorry, I have another meeting I got to get to, but this has been incredibly helpful. I've made some notes, and if it's okay, I might follow up with you and Marianne and some of the other, and Catherine and others, just to get some more details about those programs.
Would love to follow up about this, Chris. Great opportunity. Wonderful talk. Thank you so much for being here, and thank you to everybody that joined online to listen in and engage in the conversation. This has been a wonderful session.
Thanks, Jordan. Bye.
Thanks, everybody.